Hello, everyone. Welcome to the Alumni Lounge. So before I introduce our speaker, I want to remind everyone again that there's going to be a 15-minute break after the session is over. And now I would like to introduce Dr. Sanjeev Akkina. Dr. Akkina graduated from the University of Kansas Medical School and completed his internal medicine residency at Hennepin County Medical Center in Minneapolis. He then completed his nephrology and transplant training at the University of Minnesota. Sanjeev moved to Chicago in 2009 and started as a transplant nephrologist at the University of Illinois at Chicago. In 2016, he moved over to the Division of Transplant Nephrology at Loyola University Medical Center. His research interests include biomarkers of kidney disease and outcomes in kidney transplantation. Please welcome Dr. Akkina.
Hi there. Can everyone hear me okay? Yes. All right, perfect. So I was asked to talk about updates in nephrology, transplantation, and post-transplantation. So let me get a sense of my audience here. How many have kidney disease or willing? Okay. And anybody with the transplant? One? Okay. And anyone on dialysis? All right. So I've got, I think actually a pretty interesting talk then, at least hopefully it'll be pretty relevant. I was worried that it'd be mostly post-transplant and then this is all gonna be kind of stuff you already knew. So hopefully this will be an informative talk for you. Let me go over my disclosures just so you know maybe I might have some biases in my talk. So I'm gonna talk a few things about some of the clinical studies that are out there and that we're participating in. So here we're part of the Apollo study, which is an NIH-funded grant. We're also part of KAOR, which is a CareDx sponsored grant or study, and I think CareDx is one of the sponsors here. And then we're also part of the Mercury Study, which is part of Meteor Therapeutics. In addition, we're also I'm currently employed, as I said, by the Loyola University, and I was at UIC before. So kind of an overview of what I'm going to talk about is one, just kind of common questions. That's going to be my nephrology update. Essentially, kind of what are some of the common questions I hear from patients especially for transplant evaluations. Another one is then also just talking about how to choose a transplant center. Obviously, there's a lot of competition in the city, and then it's kind of up to you. How do you find which one is the one you need to go to, or which one would you think is the best one to go to? Also, I'm going to talk about hepatitis C and how that relates to transplant. And then, are there any new medications that are out there in case for those that do have transplants, in case you're curious about that? And then finally, kind of what kind of clinical trials is my transplant center going to ask me to enroll in? So just something to be aware of, like maybe somebody at your transplant center, it will ask you to participate in something. And so I'll just give you kind of some heads up on some of the stuff we're doing. So I'll start off with some common questions I hear from patients. It's basically one. Everyone keeps asking me, what about the artificial kidney? And there's probably been a lot of news on this about when is this artificial kidney going to come out? Can I get this? And it's still pretty early. So the University of California, San Francisco, and Vanderbilt have been working on this project of developing this artificial kidney. And as you can see on the picture, it actually looks pretty close to what a kidney transplant would look like. So you can see here, there's if you look at, a kidney transplant essentially is kind of implanted somewhere here onto your leg artery and vein, the iliac artery and vein, and then it's attached to the bladder. So you can see this little artificial device that's over here is kind of what they're describing as the artificial kidney. It essentially is kind of two modules kind of put together, one there is a filter and then one that actually has actual cells that actually process the fluids that go through the kidney, or through this artificial kidney. So it actually tries to resemble what a real kidney does. Pretty impressive, but I think they're still looking at trying to get funding to get this project going. So it's still probably early in the phase, but it is something that they are working on and I think has some tremendous promise in the future. Another question I may get is, how long is my kidney going to last? So sometimes I'll see somebody in the clinic afterwards and they say, well, how much longer do you think this kidney is going to last? Because usually in the pre-transplant setting, we tell you that these kidneys may last anywhere from 8 to 15 years, depending if it's a deceased donor kidney or a living donor kidney. And so after transplant, maybe 3 years later, somebody will say, hey, how much longer do you think this kidney is going to last? Kind of maybe anticipating what to do next. And so usually my answer is, I really don't know. It just depends on what your kidney function looks like. And I might say, it could be a year, it could be 5 years, could be 20 years. It's hard for me to say. What is interesting, or what's kind of innovative that's coming out, is this tool called iBox. This is a program that it was kind of launched by the group in Paris France, where they've developed, looking at using machine learning and artificial intelligence, they've been able to develop a way to kind of predict how your kidney is going to do based on the experience of a lot of other kidney transplants in the past. And they can kind of give you probabilities of what to expect. So in this, what they would usually use is what's your current kidney function? Do you have a lot of protein in your urine? Some other things like antibodies in there, maybe some biopsy information. They try to use that information, and based on that, they can kind of give you some probabilities of what maybe your 3, 5, and 10-year survival is. Like in this example, you can see it's somewhere like 75% for 3 years. It's about 64% chance the kidney will last 5 years, and in this case, maybe about 52% for 10 years. So again, it can't tell you again what your chances, how long it's going to last, but it gives you an idea of like, okay, this is something that's going to, I got a 50-50 chance in this case to say it's going to last me 10 years. So, which is pretty good in that sense. So the next one I'm going to talk about is how to choose a transplant center. And obviously, coming from Loyola, I'm going to be a little biased and say you should come to Loyola. And obviously my coordinator sitting back there, so I have to say that. So, but obviously I also went to the University of Illinois, so another great transplant center. And actually all the transplant centers in the Chicago area are fantastic. So, for me, it's hard to say what's a good one to go to. But I can what I'm going to talk about is maybe a tool that you can use to kind of help you guide what may be the best center for you. So the data would probably come from, the best place I would say probably to look at this is the Scientific Registry of Transplant Recipients, and the website is www.srtr.org. And this is the picture I show here is kind of what the web page will look like when you first come on. At the top, it'll have kind of where you can choose your organ. So if you're looking for a kidney, a heart, a lung, a liver, whatever, you can pick that. And then you can put in your zip code, or if there's a specific center you want to see how they're doing, you can type in that information. But what this will do then, and the idea of the SRTR is it's an analytic organization that is contracted with UNOS and the OPTN. So if you look at kind of the hierarchy of how this works, transplantation is managed by the Health and Human Services Department of the government, and then with that they have a subdivision called the OPTN, the Organ Procurement Transplant Network. And then what they do is then they contract out this work to different agencies to kind of do different aspects of transplantation. The one you probably most heard of is UNOS. It's been there for a long time. And so they contract out the allocation of organs and management to UNOS as that portion. And then the data analytics. So when you go to your transplant center, they may ask you a lot of questions, and maybe kind of odd questions like, are you working full time? Are you working part time? Kind of random questions that may seem a little out of character for what is relevant to what your visit may be. But these are usually questions to answer for UNOS, because UNOS is asking information about how all transplant recipients are doing afterwards. And they even ask about pre-transplant. They want to know, once you get listed, what's going on with the patient and what kind of medical issues do they have? Are they working? Because it gives an idea of the functional status and where patients will be before and after transplant in terms of employment. Just a lot of data analytics that they want to do. And so the UNOS collects that information on a regular basis, and then the SRTR processes that information to kind of develop, just to get a sense of how are patients doing, and like graft outcomes, are they being allocated appropriately, so on. So that's the SRTR. And one of the things that, the main objective of the SRTR is to provide the public information about what's going on in the transplant world, and also to Congress in case there's any oversight about what's going on. So that's where the SRTR come in and say, we're going to try to make this available to the public. How are individual transplant centers doing? And this gives you a chance to kind of see a comparison between one center to another. So, for example, in this case, we're at a kidney symposium, so I'm going to look at kidney transplants, and I'm going to try to pick a zip code nearby. So, not to be biased around Loyola, I did try to pick, basically the zip code. The only other one I really know of, which is UIC. And so I put in the zip code, and it comes up with a list of transplant centers. Now, they can be ranked in different ways. This is the way the default. I did not switch it, so it makes it look like Loyola's at the top. So, but what it does is it gives you information about a 5-tier outcome of assessment. So what they do is they kind of take the entire group, the national cohort of transplant centers, and then kind of break them up into 5 different groups based on their performance in different categories. So that's what they call as a 5-tier outcome assessment. And then these reports are updated every 6 months, and they look at patients that got kidney transplants over the last about 30 months or so about 2.5 years worth of data. So they kind of give you updated data every 6 months of how the transplant center is doing, and kind of you can look at a trend sometimes of like, I looked at it 6 months ago, and they were doing great. Now they're not doing so well. So what happened at the center? That might be some questions that you could do if you constantly look at this. But this, as I said, it's updated every 6 months based on how the newer patients are doing that are getting transplanted. And then there's also, beyond this, there's actually more detailed information that you can get. So if you go to just the brief summary report, it provides quite a bit of information about what the transplant center is doing. And I know, I'm sorry, the graphics didn't show up so well on here, but it does kind of give you some information about, one, where to find the transplant center. So it kind of almost gives you like a Google Maps approach of where is this transplant center located. And then below, it gives you some information about their wait list. So you can see, well, okay, there's this many patients that are on the wait list, and this is what happens. This is how many that went on the wait list, how many people were taken off the wait list, mostly for transplants, but could be for other reasons as well. And then it gives you a total of what the transplant number of people on the wait list are afterwards. You can also get other information about what's the transplant rates at these individual institutions. So, how long are people waiting for a transplant at these different sites? And as you can see, for like this case, it's about 30 people are getting transplanted for every 100 years of people waiting on the list. So basically every person is a year on the wait list, for 1 year. And then if there's 100 people on the transplant list for a year, that's 100 years. So in that case, 30 of those 100 people are probably getting transplanted at any one time at Loyola in this case, where you'll see like the national average is around 20 or so. And you'll see it's probably predominantly driven by our deceased donor transplants. So you can see our transplant rate for deceased donors is higher than the national average in that setting. Other information is waitlist mortality. How are people doing that are on the waitlist? And generally that may be a marker of how healthy the patients are on the waitlist, if they're pretty healthy, or if they're taking a lot of older individuals that may have a lot of other medical issues. So it kind of gives you an idea of how sick the waitlist population is on your transplant list. And then the other one is just time to transplant. How long can you expect to take? And for our center, you can see it's a little bit longer than the national average, probably driven by the fact that maybe we do a lot more deceased donor transplants than living donor transplants, because in most cases, if you have a living donor, you can get a transplant done probably within a few months. Whereas if you're a deceased donor, you may be waiting months before your years maybe before a transplant occurs. So that might be kind of one explanation. But again, this just gives you kind of a summary of what to look at. In more detail, you can see there's some other information that's available, and you can look at like what age groups is the center transplanting? Are they transplanting more younger individuals, older individuals? So that might give you some information on where you'd want to target as a potential center to go to. So again, the summary report just gives you a summary of the metrics that describe a program activity and their outcomes. So again, just a way for you to get a chance to see how can I grade a program and then see if this is the right program for me. If you really wanted to, you could go into the really detailed program report, and then this will give you, and as you can see on this, it's like I think 59 pages of data of just talking about every single aspect of our program. And this is for every transplant center in the country. So the SRTR performs a lot of work to get these reports available to anybody, so that in case you want to know any specific detail, you can certainly find it on there. Other things to consider for criteria for choosing a transplant center: insurance is obviously your biggest issue. You got to make sure that your insurance company will cover the transplant at that center. So that's usually going to be the first thing most transplant centers are going to do when you get registered is, does your insurance work at our center? If not, we'll recommend going to a different center to look at that. So obviously that's one thing to consider. Pediatrics, if you're looking, if you're looking for pediatric transplant programs, it's not common at all of them. There's, I think, 3 centers in the Chicago area. Mainly Lurie is probably the biggest one, but I think University of Chicago and University of Illinois are also pediatric programs. Loyola does not do pediatrics, or at least we rarely do them. In case, if you're sensitized, if you have a lot of antibodies, if someone has said you go to a transplant center and you said you're highly sensitized because you've had, been pregnant multiple times, you've had lots of blood transfusions, or you've had a previous transplant, those are cases where you can become a little more challenging to match the right kidney for you. So some programs do desensitization to make it easier to find a kidney. Their programs a little harder to find, and it's probably becoming a little less favorable, maybe because of a lot of the paired exchange, which we'll see here next. And that paired exchange program, basically, if you have a lot of antibodies and you have a potential donor that doesn't work with you, you can try to do an exchange where maybe somebody else can trade kidneys and maybe find a compatible one with you. So the desensitization has kind of fallen in favor more of paired exchange. But there are still programs that do the desensitization in case you just don't have a living donor that works. Obesity. So if you've been told that if your weight exceeds what the limit is for the transplant center, there are certain transplant centers that are expanding out on that, as obviously obesity is becoming more and more of an issue in the transplant world and really everywhere in the U.S. population. Some centers are adapting to that. So they are kind of either increasing their weight limits to see if they can accept more patients that way. Be aware that with those increases in weight, there are probably higher risk of infection and wound complications afterwards. So I will give props to my previous center, the University of Illinois, because they actually have quite a really innovative approach on how they do this. They actually do transplants a little differently for obese patients, where they, instead of going where your traditional incision, which would be kind of in your lower abdomen, which is a little harder to manage, they actually do use a robot to help do the transplant and do an incision just underneath your chest to put the kidney in. Really fascinating, and I think it's one of the centers where if the centers that you've gone to have said that you don't qualify because of your weight, I think the University of Illinois does a great job of looking, that might be an option to consider. Multi-organ transplants, this is where if you need something beyond just a kidney, you may have to look at other programs that do other organs. So like heart, lung, liver, pancreas, obviously those are things. Loyola does all of them, so it won't look like I'm just sponsoring University of Illinois on this one. But yes, we do all of those. And there are other programs in the city that do that. And then finally, clinical trials. If there are some clinical trials that you're personally interested in that you think might be really interesting or something that you would want to pursue, you may look at a transplant center that does that. And I'll talk about that in a little bit too. So kind of going off on a little thing, something like if you go into a transplant center, some questions may be, what kind of kidneys can you take? Do you take older individual kidneys, these high KDPI kidneys, where these are kidneys are from older individuals that may be kidneys that may not last as long, but maybe you don't need a kidney to last 20 years. You want it to last 5 or 10 years. There may be some things like PHS increased risk, which means they may be donors that potentially may have an infection or have a risk of having an infection even though they tested negative. Are you willing to take that risk to get it? Because maybe a lot of other people won't be willing to take that risk. So that's something to consider as an option as well. But the biggest one I think you'll see is hepatitis C. Now, if you have hepatitis C, I think looking at hepatitis C donors totally makes sense because if you have hepatitis C, it's not going to be a huge deal. If you get a hepatitis C kidney, you're going to pick up the viral infection. You already have it. There are some different strains of the viruses, so you could get a different type of hepatitis C virus. But in general, it's going to probably behave the same way. And the biggest advantage in the last 5 to 10 years really with hepatitis C is you have basically treatments that cure hepatitis C. So if you were to get a hepatitis C kidney and you already had hepatitis C, the advantage is that you'd probably say, I'll wait to treat my hepatitis C until after I get the kidney because then just treat it all at one time. Why does it matter? Why do I keep talking about hepatitis C kidneys? It's a group of kidneys that nobody else is going to really want. I mean, when you say you're going to accept a hepatitis C kidney, it's really restricted to a small group of people. So with that, it actually could cut your wait time down dramatically. And I'll show you some examples of this in some other cases. But one example I can give you is that we had a patient who just started dialysis, had hepatitis C. We told her, don't get your hepatitis C treated yet because it gives you the opportunity to accept hepatitis C kidneys. And she was able to get a transplant within a year. And we've actually had, I think, a couple of people like that where we actually have accepted kidneys within a year of getting on the wait list. So certainly this gives you an advantage of cutting your wait time. What on average in the Chicago area is 5 to 8 years, they were able to get transplants within a year. So there is a huge advantage. I guess if you want to say it's a huge advantage of having hepatitis C and you have kidney failure and that you could get a kidney a lot quicker. But extending that, the question would be, well, what if I don't have hepatitis C and you're telling me there is a cure for hepatitis C? Why not take advantage of that? And I'll take a hep C kidney. I'll get hepatitis C after my transplant, but you're going to cure it. Why not look at that? And there's actually a couple of centers that have thought about that and said, well, why not? Why not treat something? Why not give somebody a kidney a lot sooner with the anticipation that we have these medications that'll cure your disease? And so the University of Pennsylvania looked at this. They actually were able to enroll patients into a study where the patients were relatively new to dialysis, so they had a short dialysis time. And in the Pennsylvania area, their wait time is anywhere from 5 to 8 to 10 years. So they said, okay, well, people that just started dialysis, they're going to have to wait a long time for a transplant. Why not see if they would be interested in taking a kidney with hepatitis C, and then we will treat them afterwards if they develop hepatitis C. And so they actually were able to find a lot of people that were interested in this idea. And of course, why would you want to do this? Because why would I want hepatitis C? What if the medications don't work or whatever? What's the advantage of me? As I said, why would I really want to take this? Again, nearly everyone based on this study, they found that in the individuals down here, if the donor had hepatitis C, you can see that almost every recipient developed hepatitis C within 3 days of getting the kidney. So you're going to get hep C if you take a hepatitis C kidney. But again, the treatments have been really effective that are out there, and it's nearly 100% cure rate. So it's like, well, it may be worth it. So in this example, I put this table on here. It's really hard to see, I think, but it's basically said the average time that patients that enrolled in the study was about 1 year of dialysis time. So again, that's about 1 year of time on the wait list. And again, the wait list time is 6 to 8 years. And once these patients said yes, they will enroll in the study, and once they got registered to accept hepatitis C kidneys, their median wait time was 57 days. So they actually got transplants within 2 months of enrolling on the study. So basically, they cut their wait time from 6 to 8 years down to under a year and a half. So I find that really quite impressive that you can find a way to bypass at wait times and just say, you know what, I will take this risk because I don't want to be on dialysis for 6 years waiting for a kidney transplant. And what happened afterwards for these individuals? Well, you can see the graph here shows what their kidney function was. Obviously, the creatinine, the measure of kidney function, was high right after transplant, but you can see it all leveled off and everyone did really well, and their creatinine is stable with great kidney function. And everyone was cured of they were all treated for their hepatitis C, and everyone was cured of their hepatitis C within 4 weeks of starting treatment. So in this case, they got a virus, they got to save a lot of time, they got started on therapy, they cured their virus, and their kidneys working well 1 year out after transplant. So I think this is something that centers, I think some centers in the Chicago area are starting to adopt it. It's a little tricky in the sense because you're depending on your insurance company to approve the treatment for it, because obviously it's a new treatment and it's very expensive treatment for hepatitis C. So you have to have that guarantee that your insurance is going to pay for it. Sometimes transplant centers are going to say, you know what, we will eat the cost if your insurance company doesn't do it, we will pay for your meds. So there are some centers that are thinking about ways to do that. And I think, I know Loyola, we're thinking about doing that, but we still haven't gotten that far in actually starting this practice yet. Now, the next question you may have is, are there any new medications? If you've got a transplant, you're probably asking me, what are the new medications that are out there for transplant? What can I use down the road? And really, there's nothing new. Everything is about the same as it was 5 and 10 years ago. It's kind of transplant. That's just the way it is. It's hard to find a good medication that works for maintenance therapy. There have been some variations, but the most common one is using Prograf or tacrolimus, mycophenolic acid, and then plus minus prednisone, depending on what center you go to, and depending on your medical issues, that comorbidities that may require prednisone. There are some other newer ones of tacrolimus, some newer versions that are out there. One is called Envarsus, and this is a long-acting Prograf. Essentially, it's just a once-a-day dose of Prograf. It's similar to Astigraf, but it has some advantages over Astigraf, so that's why Envarsus has been taking off a little bit faster than I think Astigraf has. The advantage, again, is that it's a once-a-day drug. It potentially has less side effects in terms of tremor. Some people... I think tremor is probably the biggest advantage to it. Some people just also appreciate just the once-a-day dosing. It also helps with people that may be on high doses of tacrolimus, that take it maybe up to 3 times a day. So there's some advantages to using that. Belatacept is another one that's interesting. It's an IV infusion that you would get every 2 weeks for the first 5 doses, and then it's every month afterwards. It's a great drug in this. It replaces Prograf or cyclosporin. So the advantage of belatacept, and this has been shown for, with 7-8 years data afterwards, that these individuals will have better kidney function compared to people on Prograf and cyclosporin. So there is an advantage to belatacept. It's still taking a while for, I think, centers to really confidently use that as their initial immunosuppressive drug, but we do a lot of conversions. So if we find people that don't tolerate Prograf, and then we will switch people over to belatacept as an option. And then if anyone's heard of Rapamune, everolimus is kind of a different version of Rapamune, and it's a version that has been used a lot in Europe, and it's kind of caught on in the US in the last 5 years. It's twice a day versus Rapamune, which is once a day, but it supposedly has less side effects than Rapamune. So there is that benefit to it. So these are kind of maybe what you could call the new medications in transplant, but in general, there aren't a lot. And I put this letter here on the side because for those of you, which it doesn't sound like it's a large portion, but for those of you that here that are on Prograf as one of your anti-rejection drugs, there is a potential shortage that's out there. The American Society of Transplantation has noted that there is a shortage of tacrolimus, generic tacrolimus, out in the market. So there may be some issues with their pharmacies being able to fill it. And so the American Society of Transplantation has recommended alternatives, which is using name brand Prograf because that is available. And without a shortage, or switching over to long-acting ones like Astrograph or Invarsys, or potentially like an oral solution. So there are some other alternatives that the American Society of Transplantation has recommended if you do hear about these shortages. So I guess in that sense, not to worry about it too much. So the next one I want to talk about, and kind of the last one, and this one I probably spent hours talking about, and I know Judith is probably tired of hearing me talk about this all the time, but it's the clinical trials aspect. This is kind of my interest within the transplant program, and I'm going to talk about a few of the programs that we are currently asking patients to join as they come in for transplants. So there's a couple of them which are registry studies, and then there's one which is a clinical trial, which I think has some really exciting opportunities for those who qualify. So we'll start off with the registry study, and the first one is the Apollo study. So this is based off of some information about, when we talk about what's new in nephrology, and again, not necessarily new, but it's something that's kind of advanced in the last 5 years or so, is that, we know African Americans are typically at higher risk of developing kidney disease. And what's been kind of noted as probably maybe a significant risk factor for this is a genetic condition. It's a gene that's called APOL1. And there are two variants of this gene. So there's a G1 and a G2 is what they call it. And this has been associated with people developing kidney disease and end-stage kidney disease, especially in those specifically with African ancestry. So initially, the reason this gene or this mutation exists is that it's been protective among African sleeping sickness. So it was an evolutionary change that was there so that so people would survive the sleeping sickness. But then, of course, this mutation ended up leading to higher rates of kidney disease. Now, in regards to having this high-risk variant, there's about a 13% prevalence, meaning about 13 out of 100 African Americans will have this high-risk variant where they have two genes that put them at risk of developing kidney disease. About 40% of the population will have a one risk variant, which is considered a low risk. So it doesn't mean you have it; it just means you have it, but it's not at a risk. And then there's the remaining that has neither variant. So the high risk variants are at higher risk of developing kidney disease, about a 1.5-fold increase in CKD, and then another 1.9, I believe it is, for end-stage renal disease. So having these high-risk gene variants does put you at a higher risk of developing kidney disease and kidney failure. But it's not the only thing. So having it doesn't necessarily mean you're going to have it. It just means you're at higher risk of developing it. Because what we'll find is that even though there's a higher risk among this population, only 1 out of 12 individuals among African Americans develop kidney disease, and 1 out of 16 develop end-stage renal disease. So the prevalence is, while the risk is higher, it's not guaranteeing you that you're going to develop kidney disease. And I'll talk about that again in a minute. So why is this relevant in transplant? Because there is some studies showing that donors that have the 2-risk variant or the high risk alleles, essentially, are the ones, those kidneys typically don't do as well. They find that those kidneys will typically fail sooner in that. So there is maybe an association for transplant in that if you get a high risk variant kidney, that kidney may not last as long as if you got one that wasn't a high risk variant. And then also among living donors, they looked at it and they said, well, with a group out of Wayne State and Detroit looked at their African-American live donors and did genotyping on them and said, well, the live donors that had the high-risk variant, and again, these are patients that are 10, 15 years out, so this is before we knew about the variants in the first place. But they went back and retrospectively looked at those individuals, found out which ones were high-risk variants, and they found that the individuals that were high-risk variants that donated typically had lower kidney function compared to the non-high-risk variants, or the ones with the low risk. And then even after donation, their kidney function was again lower compared to the ones that the ones that had the low-risk variant. So lower kidney function prior to donation and lower kidney function after donation if you had the high-risk variant. So that was concerning, and it does kind of bring up an idea of like, okay, well, maybe APOL1 should be something that you screen for at transplant centers, and maybe you tell those individuals not to donate in that in that case because maybe they're going to be at higher risk of kidney disease and kidney failure down the road. But of course, if the I think a lot of people that bring up this concern of that say that, well, if we do that, African Americans in general are already kind of disadvantaged in getting kidney transplants, and now we're going to limit living donation based on this theoretical risk of higher kidney disease and higher rates of end-stage renal disease. So it's hard to say that we have kind of these, well, we have these studies that suggest that might be the case, but it's hard to really say, should we establish a policy that may disadvantage minorities even more? So that's kind of a concern that's been brought up about this. So what the Apollo study wants to do is they want to say, well, the Apollo study is the APOL1 long-term kidney transplant outcomes network. So this is an NIH-funded study to answer this question. Are we really looking at these risk types? Are we really too concerned about this, or is this a real problem that we should address down the road for future kidney donors and for recipients? So this is going to be an observational study. What they're going to do is they're going to follow people that donate a kidney and also receive kidneys from donors of African ancestry that have these different variants. And they're going to see like, well, is this really affect graft outcome? Is this going to be a problem down the road? And this is going to include 13 networks around the country, which is going to essentially involve every transplant center in the country. So I think everyone in the Chicago area is part of this network. So this is something that if you get a transplant in the next year or two, this is something that people may come back up to and ask you to enroll in this study. So just be aware of that as a possibility. If you hear about Apollo, that's what they're looking at. Their main objective, again, is just to determine whether the presence of the APOL1 risk variants in a kidney donor, does it shorten or does it reduce your chance of your kidney lasting? Does it kind of make the kidney fail sooner than it should? That's the primary outcome that they want to know about. Secondary outcomes are going to be, does it also lead to just things like kidney disease, reduced kidney function, or do you develop protein in the urine sooner than someone that doesn't have these high-risk variants? Also looking at the living donors, how do the living donors do after transplant or after donation in this case? And then finally, they also want to, so as I said, not everybody that has these high risk variants is going to develop kidney disease or kidney failure. So they want to know, what is it beyond just having the genetics to develop kidney failure? What other hit do you have to develop kidney disease and kidney failure? So that's kind of what they're trying to look at. So again, it's going to be the OPOs, basically the people that will procure organs from anybody that's interested in donating. If you have someone that passes away, and then you have, in this case, in the Chicago area, Gift of Hope, they come over and they talk to you. They work on the process of having that person that is deceased to make them a potential donor. Those are part of the OPOs, and they're going to consent the family members of that donor to see if they're willing to participate in the study. Then they'll genotype the donor if the donor's of African ancestry, and then these kidneys will then go out to wherever they go. They're not going to reveal the donor risk alleles at this point. They'll kind of reveal that closer to the end of the study, so that it doesn't influence who picks what kidney at this point. Because again, we don't know if this is a concern or not. But they're going to follow these individuals, and then the study centers. So again, if you get transplanted at one of the centers in the Chicago area, and the Gift of Hope says we've consented the donor, you're probably going to be approached saying, we're going to consent you. We want to see if you want to participate in the study from the recipient standpoint to see how you're doing. And so that would just include blood samples and urine samples and just the regular tests that you would normally get as part of your transplant care. And then the same is true also beyond just the deceased donors. There's also living donors. If you have a living donor that with African ancestry, they'll be asked to participate as well, just to see how they do after donation. So that's the Apollo study. And again, that's probably one, again, if you get transplanted the next year or two, I think that's one that you probably will be approached. There's a good chance you'll probably be approached or hear about the study. So the other one I want to mention from a registry standpoint, meaning again, this is just a group of people that get tested and we're just going to follow, is the KAOR study. And so what the KAOR study is essentially, it's a test that looks at cell-free DNA. So you're probably asking me, what is cell-free DNA? And what it is that these are fragments of DNA that goes into the bloodstream. So this is, cells break down, it releases the DNA, it floats around in your blood. And then the liver and the kidney are always clearing this. So it doesn't last very long. This DNA will usually go away within 30 minutes or so. So it's something that's cleared pretty quickly. And it's a very small molecule. So how can we use this essentially in transplantation? And so, you will have your own DNA kind of floating around. That's the cell-free DNA, and that's going to be predominantly, 99.9% of the DNA that's floating around. With a kidney transplant, if the kidney's working well with no issues, there shouldn't be any DNA released from the kidney. So you should have a very low percentage of the donor DNA. But if there's some evidence of injury, if there's some damage that's going on to the kidney, either because of a rejection or inflammation, urinary tract infection, viral infection, something like that, that may cause some kidney damage, and those cells are going to release the DNA, and that's going to float around in your blood. And that's what this test is measuring. Is there any kidney damage that is occurring? And so in this case, if you have someone with nothing going on, you may have like just a little bit of donor DNA floating around, but it's predominantly yours. But in the setting of active rejection, you may have 2 or 3 compared, with less of your own DNA in there. So again, it gives you a percentage of, if you see a higher percentage of donor DNA, that's a sign that there's something going on in the kidney. In regards to how they validate this test, there's a multi-center study that looked at 14 transplant centers, 384 patients. They had about 100 and some biopsies, and about 27 of these individuals had a kidney rejection. And there's a lot of data on here. Really, the key thing I just want to show or highlight about this test is that individuals that have really low levels of cell-free DNA floating around are typically going to do well with no rejection. Individuals that have higher levels of cell-free DNA typically may have rejection, and there may be a concern for rejection. Whereas if you look at our typical marker, which is serum creatinine, you can see that the levels are pretty similar in the case of people with rejection and without rejection. So while we use serum creatinine on a day-to-day basis to measure kidney function and transplant function, this test is actually trying to argue that we're much more sensitive. We can actually detect injury a lot sooner than your kidney function test that you use on a regular basis too. And the advantage I like about this is that what this means to you is, one, we can detect kidney injury sooner, but also if we see a change in creatinine, but we see a low cell-free DNA test, this actually may save you from getting a kidney biopsy, which, again, kidney biopsies are pretty safe in transplants, but if you don't have to do a kidney biopsy, I'm sure you probably don't want to. And again, and while we say it helps detect rejection, it seems to actually predict out an antibody more severe rejections better than it does the less severe rejections. And that's still a pretty valid use for it. So great for severe rejections, maybe not so great for moderate rejections, but really good if nothing is going on. And so the key messages from the study is that you can differentiate active rejection with no active rejection, a huge benefit that serum creatinine obviously didn't show, and that it does a really good job of detecting a severe rejection, antibody-mediated rejection versus a no antibody-mediated rejection. And then the other thing that we could use this test for is, okay, if you do have a rejection, most of them are very treatable, and what we do is we would just treat you for the rejection, and then we can follow this cell-free DNA and make sure that it does go away over time to suggest that you're doing better with your kidney transplant. So the final study, and then the KAOR, essentially when I mentioned it, KAOR is the Kidney Allograft Outcomes AlloSure Registry. Basically what a center may ask you to do is, hey, we want you to participate in the cell-free DNA study. What we're going to do is we're going to ask you to do these tests with your regular blood test. So it won't be an additional blood test, but it'll be with your regular blood test to do a blood test at 1, 2, 3, 4 months, and then every 3 months afterwards for about 3 years. And the study will like to know your information. Basically, what they're asking for is how is your kidney doing? What's the kidney function? Did you have a biopsy? And basically, they just want to know how you're doing, so they can correlate test results with your function. And the goal is they want to enroll about 1,500 patients around the country, so that it goes to a much larger case of what the study did, and they can just validate this and just make sure that this is a test that is actually helpful to transplant centers. And in the future, there is actually this study goes beyond cell-free DNA, but they're actually using another version which also looks at activity of your immune system, which is called AlloMap. This is a test that's currently used among the heart transplant patients, but certainly has an opportunity to be used also in kidney as well. And then it does also incorporate the iBox thing that I mentioned at the beginning, which can help predict how long your kidney may last. And finally, I'm going to go over the Mercury study, and I'm going to go over this. There's a lot of detail in here. And really, I'll kind of highlight the key points of the study. But this is a study that we've been involved in for the last about 1.5 years or so. And the idea with the study is that we want to be able to get people off their immunosuppressive drugs. We want to get people off their anti-rejection drugs. And how do we do this? So this first study, the Mercury study, is looking for individuals that have HLA identical donors. So potentially like a sibling, brother, sister, potentially parents. If they're basically a perfect match kidney, we want to we would potentially enroll them in the study. And then the idea would be that we could take you off your anti-rejection drugs at 1 year out after transplant, and then you wouldn't need them anymore. Again, the rationale is that kidney transplant is the most effective way for kidney replacement therapy, and it does require immunosuppressive drugs or anti-rejection drugs, which do a great job preventing rejection, but they do have a lot of potential side effects, which include diabetes, heart disease, cancers, and toxicity to the kidney itself, especially with the Prograf or with the cyclosporin. And if you try to reduce the anti-rejection drugs, there is the risk of the body rejecting the kidney as well. So that's kind of the challenge. How do we find a mix to get that? How do we find a way to have your body adapt and be able to do a kidney transplant without medications? So what this study is doing is we're taking the stem cells from the donor, and then they're going to, what we do is then we infuse the stem cells into the recipient after the transplant. And what that'll do is it'll give you a mix of both your own immune system and the donor's immune system together. And then it reprograms the body to say, hey, this kidney transplant from the donor is now part of the recipient, so don't damage it. So that's the idea behind what this study is doing. So they wanted to focus first on the easiest population, which would be the perfect match kidneys. Again, the primary objective is to get people off their medications at 1 year and follow patients out 2 years out after that and see if they can stay off their medications without any evidence of rejection or problems with the kidney. Obviously, safety outcomes, they just want to make sure people tolerate this well too. So there's 2 arms. If you are enrolled in the study, it is a randomized study. They're randomizing 2 people to the study to 1 person in the control arm. The control arm is you just proceed with a kidney transplant, continue on your medications like you normally would. And then the other option would be doing the study or the investigational arm where they would we would start doing the therapies that you require to undergo the transplant and also get the stem cells from your donor. So the first question, or the main question I always get asked when I try to enroll patients into the study is, does it work? And so this is kind of data that's from Stanford University. They've actually been doing this protocol for a while, and they've had 28 patients enrolled in their study. These are, again, HLA perfect match kidneys. And you can see that 27 out of 28 individuals were actually able to develop that mixed chimerism, which is, again, the donor and recipient immune systems kind of merged together. And out of that, 24 of the 28 were actually able to maintain that. So what happens, some of the individuals get the donor cells, but then they immediately kind of kill off the donor cells, so it doesn't maintain that mixed immune system. But 24 of the 28 were able to maintain it. And then 23 of the 28 were able to actually start coming off their medications. And then of this, 18 of the 25, there were still 3 that were in the follow-up period, were able to maintain off their medications for 2 years after they were taken off. So it's about 3 out of 4 individuals were able to come off their anti-rejection drugs and do really well. And you can see in that last bar here that 96% still have a functioning kidney out 5 years out after transplant. So, I think it's really exciting. I think there's some there's great potential in that you can actually get your transplant and then be able to come off your medications and potentially have less side effects, cheaper costs because you don't have to pay for these expensive medications, and hopefully less follow-up in the long run, though for our study, that's not going to be the case. And then, of course, safety profile, overall people did really well with minimal side effects after the transplant. Results of this, so that's from the Stanford study. Now with this multi-center study, we have our goal is to get 30 patients in this study. Right now there's 18 patients nationwide in the study. There are 5 people in the control arm, 11 people that were randomized to the investigational arm, and 1 that's still being randomized at this, or in the process of being randomized. So they've got about 18 of the 30 so far into the study. 1 dropped out after randomization, another 1 failed the screen, meaning like they were initially a candidate, but then something happened and no longer a candidate. And 4 of the subjects had begun weaning off their immunosuppression. So overall, most common side effects to watch out for: bone pain, which is typically in the donor because they're the ones that are donating the stem cells, and the treatments to get the stem cells require injections, which can cause bone pain. So that's been one of the side effects, but the donors do well after they stop the medication. Nausea is another common complication that they see, but again, not surprising after a transplant. And then overall, somebody had some mild adverse event, but most of the adverse events have resolved. In regards to this chimerism that I talk about, again, the mix of the donor and the recipient immune system, overall, everyone's been doing really well in the study. And so this is where I think it's a promising study that I think, that might be considered, especially if you have a perfect match donor. This would be, I think, a fantastic study to look at. We're currently doing the study. University of Chicago, I believe, is also in the study as well. So there's a couple of centers. If this is something that interests you or you have a potential for this, let us know, or certainly something to think about. And then, of course, future research, the company does want to do this for HLA mismatch people, so the more common kidney transplant you see. So maybe, again, somebody that's not a perfect match, they do want to see if this applies out to that population as well. It's going to be a larger study, 172 people. It's going to be the same protocol, essentially, on how they do it. And that study, they're hoping to start mid-2020, and we're hoping to be part of that one. And then if you have received a kidney transplant and was from a HLA matched or a perfect match person, they are also doing a study that will retrospectively let you be able to take you off your immunosuppression medications. So that's also coming out there next year. So overall, again, hopefully I addressed kind of a lot of these questions that you may have about transplant, and I'm sure there's a ton more, but hopefully I answered these. And do you guys have any questions? Yes. Yeah, so they haven't gotten there yet. They're looking. That's, I think, one of their future trials, but that's going to be probably years away before they get to that. So right now they're kind of focusing on the living donors because for them that's the easiest ones they can get the stem cells from. So, and the stem cell, it's kind of that's what I have to also. Usually when I consent patients, I have to consent the donor first because usually the donor just goes through the surgery and moves on. In this case, now I'm asking the donor to take a bunch of these shots. It's going to be 6 shots where we're going to boost their blood counts up tremendously. They can get bone pain from it. And then we're going to ask them to get probably a dialysis catheter so that they can go through apheresis to donate the stem cells. And they may have to do that twice. So it's a lot of work for the donor to do it. But so far, we've had pretty good luck with that. So, yeah.
Regarding CKD, we know that high blood pressure is a factor of risk. But we also know that perfusion of the kidney is important, and therefore low blood pressure is also a risk. Which is the greater risk, in your opinion?
So it's a good question. I mean, I think there's data coming out from Sprint, I think is a more recent trial that's come out there that goes with really aggressive blood pressure control. And that study was actually stopped early because they found that the individuals that had really aggressive blood pressure control actually did better. So, and I think renal outcomes was one of the ones they were looking at because they had individuals that were at high risk of potentially developing kidney disease, and they found that still low blood pressures are still pretty good, better than probably maintaining high blood pressures. So the side effects though of Sprint is that some people there's probably more passing out associated with it. So there is that challenge with trying to how low you can go with your blood pressure. But I still target, especially for our transplant patients, I still target like 120 to 130 as a goal. If they drop below 100, I get a little concerned. But anywhere between 100 and 120, 130, I'm pretty happy with.
So below 100
makes.
Simply a pass out?
No, not yeah, maybe. I mean, but you'll see like a lot of individuals with normal kidney function have blood pressures in the 90s. So that's also a blood pressure people can tolerate really well. I think if you can kind of gradually bring it down to like, if you keep it in the 90s to 100s, I personally am a little concerned about people that are in the 90s, especially if you're on blood pressure medications. If you maintain 90 without blood pressure medications, I may not be as concerned about it. But if we're medicating you for it, I wouldn't want to be that aggressive.
Creatinine levels and GFR.
Mm-hmm.
I was told, however, by many that GFR tells you what your percentage kidney function is, whereas creatinine can vary based upon how much water you drank in the last couple of hours. Does the GFR?
How does it change too? It will, because it's a response to hemodynamics. So if your blood pressures are high or your blood pressure, if your volume status is high or low, your kidney is going to change a little bit too. So, but creatinine, when you ask for GFRs are calculated based on serum creatinine, as well as age, ethnicity, and gender. So essentially creatinine and GFR are the same. It's just you use an equation to the GFRs that you typically are probably being told about. The only way to really get a GFR is to do a measured study, which is, you get an IV infusion of something and then they measure how fast that thing is cleared from your body, which is usually a half-day process. But the quick kidney test you get with the blood test, that's typically an estimated GFR, and that's calculated from creatinine. So in that case, they're the same.
So therefore, 52 to 73
Mm-hmm.
in a 2 or 3 month period, and it may be yo-yos
Mm-hmm.
that may simply reflect how much water was drunk before the.
Right. And that which changes the creatinine and yeah.
So only the one that's done over a period of days would be reliable.
A measured GFR. And even that's also dependent upon how much water you drink or so on. So yeah. So it measures your GFR, but again, it's still dependent upon how much fluid you have and how your body's regulating it. So
Some articles allege that cystatin C tests are the only reliable kidney function test. Do you believe that?
I love cystatin C. So it is one that I think it's not one that a lot of centers use on a routine basis. So it's a little harder to get. I really do like it. And I'm trying to push our center to try to use cystatin C for our donors to see if we can get better ideas of what kidney function is. But
What is the goal then for cystatin C?
it's a little different. It has its own equation, and there's actually even combination. There's even an equation that uses a combination of cystatin C and creatinine to help give you a better estimate of your GFR. So I wouldn't look at cystatin C by itself. I'd use cystatin C to put into an equation. So to give you, it just gives you another way of measuring GFR. Again, GFR calculated with cystatin C.
What cystatin would you be happy to see?
Which creatinine versus? That's a good question. I don't know if I have a good answer for that one. So I put it into a GFR and go with that. So looks like my time is up. So if you guys have any questions, feel free. We can meet after, or I'll be on the panel later on today. So.